Okay. Hello. Yes, I realize it says I put the fourth here. I know it's the fifth. I literally have no idea what day of the week it is this week. Always happens after break. But I hope everyone had a good break and that no one's flights got canceled like mine. Yes, it happened. But okay, here we are. So just this is like my thing I'm gonna put on now, just in all of my PowerPoints just in the beginning. If you've never seen any of my power or lectures, whatever these are, everything I say is like, oh, this is important. I know I don't think you need to know this. That's like just from what I've seen over like the past 4 years of like doing medical stuff. I don't have anything to do with exam writing, even though I do facilitate from time to time, but I just want to like emphasize that I have literally no idea what's on your exams, which is probably a good thing because my exams from 4 years ago were wild and they're a lot better now, which is good. But okay, so just wanted to put that in there. So what I did was, since these are PowerPoints that I've had in the past, I've tried to include more of what's on your syllabus if I have time. I wasn't able to put embryo on this just because embryo, like for like the repro block, is like huge. Also, embryo is technically not allowed to be tested on Comlex. I know we've talked about that before. They can ask embryo, but like it always has to be in the context of path. But step is like classic embryo. Like what germ layer does this derive from? That's what step does. So if you're not planning on taking step, I think that's just a waste of time to watch that. So I'll eventually do some embryo if you guys want it. But just know that that's really not super, super important on Comlex. Okay. But this is pretty much all the anatomy I'm covering today. And I threw in some path here and there when I thought that it was relevant to the anatomy. Okay. Okay. So, see if I can move the, okay. So, anatomy. Sorry. I feel like WebEx updated and now I feel like one of those professors that doesn't know how to use technology. Okay, so to start off with the thalamus, hypothalamus, and pituitary gland. I want to start off by saying these are like neurostructures. Technically, like the pituitary gland is probably the most endocrine structure, but the thalamus and hypothalamus, like those are in the brain. So anatomy was kind of tricky. I didn't want to give you too much neuro because you're going to cover this again in neuro, but I still gave you the anatomy for it, but just keep that in mind. So for example, with this, the thalamus, like, again, you're going to go into so much detail with this in neuro. And this is one of those things where I'm going to say, like, I don't think you need to know this, even though you know PBL, but I really don't think you need to know, like, all the little nuclei of the thalamus. It's not in this block. Like, I really don't think so. And hopefully, well, actually, this probably won't make sense to you right now because, again, you haven't had neuro, but this is the anatomy, right? So it's located above the midbrain, which is a part of the neuro system. And it's a part of what's known as the diencephalon. Again, cover it in neuro. It gets divided into lateral, medial, anterior, and then intralaminar nuclei. And why I at least wanted to mention it is because there's some that are going to come up later in neuro, so at least you'll see them here. But the blood supply for this is mainly a cerebral artery called the posterior cerebral artery. It's one of the three main cerebral arteries. Okay. Really don't know how much anatomy to know about that because, again, very neuro. Same with the hypothalamus, but we're starting to get a little bit more relevant to the endocrine system. So this is the hypothalamus, right? So hypo, it's below. So it's ventral and inferior to the thalamus. It's also a part of the diencephalon. The diencephalon is just like a neuro term that means the thalamus and the hypothalamus together comprise that. You'll get it in neuro. And the hypothalamus is composed of four nuclear groups, and you can see them over here. They're like in the boxes: the supraoptic, the tuberal, mammillary, and preoptic. And I highlighted the supraoptic because these are the ones that are relevant for endo. So you've probably, if you've started endo, I don't know if you guys have yet, but pretty early on, Costanzo will talk about, the supraoptic nucleus and the paraventricular nucleus. Those are really involved in the endocrine system. Those are the ones that are going to be secreting some hormones that are going to go to the pituitary gland. Okay, so that's what it's referencing. It's these like nuclei. So literally like these little number 3 and number 5 are just like these little bulges that are a part of this supraoptic nuclear group, which is a part overall. So the whole hypothalamus is this whole thing here, is this whole thing. We're talking about specifically this group, and then specifically related to endo is 3 and 5, if that makes sense. And again, you'll go into all the hypothalamic nuclei in neuro. People hated studying the hypothalamic nuclei. It's like one of those things you have to just make flashcards for. I don't think you need to know it for this block, but definitely know those two. Those are important. So the supraoptic and paraventricular. This blood supply is mainly supplied by what's known as the anterior cerebral artery, which is another one of the three main cerebral arteries. Okay. And then now the pituitary gland, yes, still technically neuro, but now we're getting into like where they can start asking some questions for endo. So the pituitary gland is located in what's known as the sella turcica. And the sella turcica, this is like the big anatomy thing. It's like the only thing located in the sella turcica. So when they talk about procedures, when they talk about anything involving the sella turcica, they're talking about trying to get to that pituitary gland. And I found this cool picture of it over here. So the sella turcica, it's like there's this bone, it's called the sphenoid bone. It's just like in your head. You'll cover it in OMM when you get to cranial OMM. You talk a lot about the sphenoid bone. But regardless, the sphenoid bone kind of like divots. If you can see on this image, it like divots like this. That divot is the sella turcica. The pituitary gland sits right in that. So you can imagine if there's like a pituitary gland tumor or there's something where they need to remove it, they'll usually mention like, oh, we got to get to the sella turcica, which is a part of the sphenoid bone. Okay. Some other things, it's connected to the hypothalamus via what's known as a pituitary stalk. Another name for this is the infundibulum. And I wanted to point, anytime that there's like, oh, it's also known as this, they're going to be interchangeable everywhere. So I wanted to highlight those so you're not super confused. So the pituitary stalk and the infundibulum are the exact same thing. So if you see that, it's the same thing. So here's the hypothalamus up here, and then here's your pituitary gland. There's two lobes of it. And the hypothalamus connects to the pituitary via this infundibulum. Okay, and then getting into the lobes, there's anterior, posterior, other names, again, interchangeable. So I actually think on my exam, this was a question. It was like the other name for the anterior lobe or the other name for the posterior lobe, something like that. So the anterior lobe is also known as the adenohypophysis, and then the posterior lobe is known as the neurohypophysis. And the adenohypophysis, this is like an embryo thing, but this is like always asked. So I highlighted it. I put a little clinical correlation image thing. I don't know. I just thought it was fun. But so there's this specific tumor that can develop from what's known as oral ectoderm. I have a picture of this on the next slide if you want to go look at it as I'm talking. But it's basically like the anterior lobe of the pituitary gland develops from oral ectoderm, which is like it's a part of the mouth, which is super odd. And it's called Rathke's pouch during development. And we'll talk about the clinical correlation on the next slide. The posterior lobe develops from just neural ectoderm. So this is a very neural structure. They're like totally different, the anterior lobe and the posterior lobe. And I'm making such a big deal about this because they've asked so many questions about the difference between these two lobes. So we're going to talk about that for the next few slides. But just wanted to, so this is one structure, but the two lobes develop from different embryologic locations. So you can imagine there's going to be different tumors that are going to arise from maybe the anterior lobe or maybe the posterior lobe and so forth. Okay, we'll get there. So here's another, so this is kind of like, what does that mean that it develops from Rathke's pouch? You can kind of see here, like so the neural ectoderm is in yellow, and then the oral ectoderm, literally, from the mouth, is in reddish orange. And during development, they kind of just start like fusing together. And that's when you get your overall pituitary gland. So again, two totally different structures that are forming this one gland, which is interesting. So here's your clinical correlation over here. There's something called a craniopharyngioma, which is a very just fun word to say. You'll talk about this a lot in neuro, but it does come up in endo. Like this can 100% be a question that you see. A craniopharyngioma is a pediatric brain cancer that develops from Rathke's pouch, like exclusively. So if you're an endo block, which you have an advantage with first year because you haven't had like tumors yet with second year, but with first year, it's like if you see like a child that has a headache, you're like, oh my God, it's craniopharyngioma. But they'll ask about like, oh, where does it develop from? It comes from Rathke's pouch. Rathke's pouch, what is that? It's oral ectoderm. Okay. And then here's just another, I know it's kind of hard to see, but this is literally, again, how you get this. And then notice here, though, I liked this picture because this is the hypothalamus right here. So hypo right here. the stalk, so this is your infundibulum. Notice how the infundibulum connects just to the posterior pituitary gland, right? So it's like you have like this very like neurologic, like the posterior pituitary gland is a very neurological structure. It develops from neural ectoderm. It's called the neurohypophysis, and it's directly connected to the hypothalamus. The anterior, the pituitary gland, is not directly connected to the hypothalamus, and we'll talk about this, I think, on the next slide. That's very clinically relevant. Okay, makes sense so far? I think I'm getting at all the important stuff about this. Oh yeah, here's another thing about this. So the blood supply here is the anterior lobe. So obviously, again, they have two different location, like they have two different places that they derive from. They're gonna have two different blood supplies. So the anterior lobe is supplied by the superior hypophyseal artery, which is a branch of the internal carotid, and then the posterior lobe is supplied by the inferior hypophyseal artery, which is a branch of the posterior communicating artery and internal carotid arteries, which I know doesn't mean much to you guys yet, but these are all arteries just like in the neck and in the brain, and they all just send off these little branches. But you can see here, just in terms of blood supply, two different blood supplies, again, two different like embryologic development sites. And then this is kind of getting at what we're going to talk about later, but these yellow things are neurons. And again, notice how there's neurons directly connecting the hypothalamus to the posterior pituitary gland, and there's no direct neural connection to the anterior pituitary gland. So this is like another big difference between the two, like the anterior and the posterior. Okay, so some histology. So the pituitary gland, histo does kind of come up it's starting to get a little bit more frequent now moving forward. But there's three major cell types that are within the pituitary gland. So there's acidophil cells, basophil cells, and then chromophobe cells, chromophobia, acidophilic, basophilic. Acidophilic, when you see this term, like it's an acidophile, it means it likes, because remember, phil, it means likes. So it likes acids, and acids in the H&E stain. So H&E stains, it's always that pink and purple stain that you see when you see like a histo slide. The acid part of the stain is eosin, and it loves eosin. So it's going to stain bright pink. So they literally just name these cells because they stain pink. They're like, they're acidophils. Yeah, okay. And then these guys secrete prolactin and growth hormone. Your basophilic cells, these stain blue. They're going to really bind strongly with that hematoxylin, which is more of like a basic stain compared to the eosin part is more acidic. And then this is going to secrete FSH, LH, ACTH, and TSH. And how people remember these hormones is B flat. So B for basophils, and then FSH, LH, ACTH, and TSH. And then your chromophobic cells or your chromophobes, these are just everything else that's there. So they don't stain well and they don't secrete hormones. They're just kind of like there. Okay, so these are the main cell types in the anterior and the posterior pituitary glands. Just like doing this, I like realized I didn't have a picture of like just the brain, just showing where all these things are. So here's just a picture of the brain. It's a cross section of the brain. If you were to cut it, down the middle. Like if this was like one lobe of the brain, it cuts it down the middle. What is that? I think it's a sagittal cut. So it's a sagittal cut straight down. This thing in yellow, that's your thalamus. It just looks like a little, I guess, circle oval thing. Right below it is the hypothalamus. So it's not really like a structure to point to, because remember, it's like a bunch of different nuclei, right? So technically it would be like thalamus is this bulge thing, and then the hypothalamus is like, boom, it's like this, just below the thalamus. Acidophil and eosinophilic. Oh yeah, sorry. So eosinophilic just means it likes eosin. But yeah, so they would, in this instance, they would be the same. Yeah, they would be considered the same things. Because like, on peripheral blood smears, you can see eosinophils are increased. It's just, those are just white blood cells that like eosin. So they stain like bright pink, if that makes sense. I think the actual cell type name is acidophil, but they're they're kind of the same thing. Whoever made this just kind of was trying to be like, oh, look, eosin, it stains with eosin. This one stains with like hematoxylin, which is a basic stain. I don't know, whatever pollution. But yes, they're the same thing. Okay, so thalamus, hypothalamus, and then the pituitary gland is below it here. So you can kind of see like where all these glands are. In this image, it would be like, just, again, it's a very general type of thing. Like, okay, here's the thalamus, here's the hypothalamus, and then here's the pituitary gland. It's just like, they're like these just areas. Okay. So this is also kind of getting back into looking at the important, I think I added, yeah. So this is again, just zooming in again, hypothalamus, here's your infundibulum, which connects directly to the posterior pituitary gland, and then your anterior pituitary gland's not connected directly to the hypothalamus. And so here's this. So the big thing about like a big difference between these two is again, note that the hypothalamus has these neurons in like bluish gray, and then they directly connect to the posterior pituitary gland. So what's going to happen? I put this over here. So what things are made in the posterior pituitary gland that like so all the hormones are made in the pituitary, right? Or they're secreted by the pituitary gland. There's only two that are like the posterior pituitary gland is primarily associated with, and that's ADH and oxytocin. ADH, I don't know if you guys remember, but from cardio, we kind of talked about this. Another name for this is vasopressin, so interchangeable. So we have ADH and vasopressin, same thing, and then oxytocin. Those are produced and secreted from neuroendocrine cells from the supraoptic and paraventricular nuclei. So remember, these are going to be in the hypothalamus. And I color coordinated, the supraoptic secretes ADH and the paraventricular secretes oxytocin. I will mention there are some sources that say like, the supraoptic can do both, the paraventricular can do both. I have seen sources say that. I think I just went with what Costanzo says, so that's you're good to go with that. But I would definitely know like, the supraoptic's ADH, paraventricular is oxytocin. So they're made here, right? So they're going to be made up in here in these neuron cell bodies. They're going to be transported like all the way down. Like they're brought to the posterior pituitary. Like they travel there. So they go through that infundibulum. And then they get released into the bloodstream all the way down here in the posterior pituitary. This is way different from how the anterior pituitary receives its, like the hormones that it needs to secrete. So literally everything else, FSH, ACTH, whatever, all those other things are going to get released. They're going to be made up here by these neurons in the hypothalamus, and then they directly get secreted into the bloodstream. So I know this is showing the bloodstream really far down. Sometimes the bloodstream can be shown like really far up. I think there's another image. No, where was that other image? Like see how like the bloodstream can be all the way up here. It doesn't really matter. They're just getting secreted. Like that's the big difference with the anterior pituitary is that they're getting directly secreted into the bloodstream. And then from the bloodstream, that's how they get to the anterior pituitary. That's like a huge difference. Everyone harps on that. So definitely know that. And there is like a clinical reason that I do keep harping on this. I think I put a slide in. So this is called the hypothalamic hypophyseal tract. So again, if we look at this picture for the 35th millionth time, they're going to be made here, your paraventricular supraoptic nuclei, and they're brought down from these axons and then released into the posterior pituitary, and then that's when they're released into the bloodstream. Before every other hormone that the body that this is responsible for, like everything that's not ADH and oxytocin gets secreted into the bloodstream early and then gets into the anterior pituitary gland. And then that's how it gets into like your systemic circulation. Question. Is ADH and oxytocin stored in the terminal axons of the neurons from the hypothalamus, or is there a structure in the posterior pituitary to store them? It's a great question. I'm pretty sure they're made and then they just travel down the axon. I guess they can be stored. I don't actually know the answer to that. That's a really good question. I guess they can get stored in the terminal axon. I don't believe there's an area in the posterior pituitary that stores them. I think the posterior pituitary just basically receives them and then secretes them. I really don't know the answer to that. But just like thinking about it, just like I know, like I think of the posterior pituitary gland as like a very neural structure. So I just think like it secretes them, it gets the axons, it secretes them type of thing. Okay, so this whole thing is called the hypothalamic hypophyseal tract because it's the hypothalamic and it's coming from the hypothalamus and going to the hypophyses, whether it's the adenohypophyses or the neurohypophyses. So here's a picture from Costanzo, and you can kind of see which gland is which. She kind of drew it backwards here for some reason, but you can tell that this is the anterior pituitary gland on the right. Over here because all of the hormones are getting secreted into the bloodstream first, and then there's cells in the anterior lobe that then that then secretes it into the systemic bloodstream, right? Versus the posterior, it just goes down. This is the infundibulum, and then it goes, and then once it's there, then they get secreted to the target tissues. All right, so why am I making such a big deal about this tract? Why did I put 25 slides on this tract? So usually this is something I try to do. Like this is, I feel like a benefit, right, of tutoring, not just like looking videos up on YouTube. I always try to give you guys buzzwords and vignettes. So remember with GI, and we were talking about vitamins, I was like, if they say alcoholic and they're asking about like a vitamin, they want you to think like this guy's not eating. It might be different for different, like alcoholic might be used differently if they're asking about a neurologic question. But if it's a GI question, no nutrition. You'll see this block when you get to like when you start getting into more of the path. If you see like the term competitive gymnast, that always is like, oh, that girl's not getting her period. And it's a type of amenorrhea, which is not getting your period, called functional hypothalamic amenorrhea, which is a really interesting thing, which you guys will eventually talk about. I'm sure you'll actually have like a PBL case on this. But that's that's just, these are buzzwords. For endo, like another thing with endo is if they mention anything that a patient's in a car accident, and now you're like, okay, this is an endocrine related question. They talked about a patient in a car accident. They are straight up talking about this, number 6. And I found this in Costanzo, and I'm like, aha, I knew it. I knew that because they always ask about this. And we're not doing this. Don't answer these questions because again, you haven't really done physio yet, like this physio yet, I assume. I mean, we just started the block. So we're not going to do it, but I'm even showing like car accident that severs the hypothalamic pituitary stalk. Basically, this is telling you that only the posterior pituitary gland is going to get affected, right? Because that stalk is really only important to get ADH and oxytocin. All right, ADH and oxy, well, okay, AD and ox for ADH and oxytocin. Those are physically getting brought to the physically getting brought to the posterior pituitary via that infundibulum. So if this whole thing gets severed, right? So if this whole thing gets severed, boom. This posterior pituitary, no ADH, no oxytocin. How about all the other hormones? What about TSH? What about ACTH? What about LH, FSH? They're fine because they get secreted up here into the bloodstream, and then now they're in the blood, they can go wherever. I mean, I know it's not great. I mean, this is severed, but in theory and in practice questions and in exam questions, it can still get to the anterior pituitary gland. Does that make sense? Because they're kind of saying with a car accident that severs the stalk, you're directly cutting off the axons that are carrying ADH and oxytocin. You're not cutting off the axons that are carrying all the other hormones because they're just getting secreted into the bloodstream. Oh, I love that. See? A vegan with a B12 deficiency. See? I'm telling you, there's always these little buzzwords that they always mention all the time, and I try to bring them up whenever it's relevant for you guys. But yeah, this block, competitive, look out for your competitive gymnast, because that's what they have. But yeah, car accident, and you can tell that it's like an endo-related question. They're primarily asking about ADH and oxytocin. So the questions here, like, we're not going to do them, but pretty much the only ones that are going to be affected are the ones that are ADH and oxytocin relevant. Okay? All right. Cool. Okay. So that was all the thalamus, hypothalamus, and pituitary gland. The pineal gland, there's nothing to it really, but we have to do it. We have to cover it because it's on your syllabus. But this is an endocrine gland named after its resemblance to a pine cone, which sure, I whatever. But it's located back here at the base of the brain. So now that we know some structures, here's your thalamus, here's the hypothalamus, it's just kind of like there, here's your pituitary gland, and then back here is your pineal gland. So it's kind of like at the base of the brain, like sometimes they'll say like, oh, it's at the base of the brain because it's just behind all these other structures. These contain special neurons called pineal sites. It's not very creative, but they secrete melatonin. So the pineal gland is very, very important for secreting melatonin. So you can imagine that this is really important for your sleep-wake cycle and your circadian rhythm. Another thing too is, we're still in the brain, so there's going to be some neuro terms that you're not going to really truly know yet. But the suprachiasmatic nucleus, this is really, really important. It's a brain structure. You will cover it in neuro, but it's really important for establishing circadian rhythm. And this suprachiasmatic nucleus sends input to the pineal gland. And basically that tells the pineal gland like, hey, like it's light out. like stop secreting melatonin, or hey, it's super dark out, can you like secrete, or it's time to go to bed, like let's secrete some melatonin. Okay, and then its blood supply is branches of that posterior cerebral artery. So we've covered two of the three main cerebral arteries that are supplying some of these structures. And then here's another picture of it. Don't worry about ventricles. You'll cover that in neuro. But here's your pineal gland, which I guess it looks like a pine cone, but it's all the way back here. This would be like roughly where the thalamus is, hypothalamus, and you can't really see the pituitary gland, but it would be like somewhere down here. Okay. All right. Thyroid and parathyroid. The first thing I want to say with thyroid is do not confuse it with the thymus. So the thymus was on your study guide. I will put, or on your syllabus. I'm not covering the thymus in this at all because the thymus is an immuno organ. It was kind of like me like refusing to cover the spleen in GI because it's just not. Like the thymus is an immune organ. It's really has nothing to do with the endocrine system. But I think it was on there to not confuse it with the thymus. Okay, so just don't get got on that one because people still get got. Like still like doctors will get got with that. They'll say like, oh, your thymus is enlarged, and it's like no, it's just not. It's your thyroid. It's your thyroid. Okay. But some anatomy stuff. So this is located at the front of your neck. So if you can see here, like you can't really, I don't know, but it's located like right around here. You'll actually learn in like H&P, I think whenever you do ENT, you'll learn how to like detect if a thyroid's enlarged or whatever. It's just right here. So the levels is around like C5 to T1. So if you were to like the back, yeah. This, it looks like a butterfly. So here's your thymus gland. Oh my God, I just did it. Oh my God. Oh my God. Thyroid gland. Oh boy. So here's your thyroid here. It looks like a butterfly. And always remember anatomy brain. I found a picture that I really liked, but it was labeled wrong because they didn't do anatomy brain. So remember anatomy brain. So the right lobe's over here and then the left lobe's over here. This is the front and then that would be the back. And we'll talk about parathyroid after. But you can see it kind of does look like a butterfly. And then there's two main, so for whatever reason, thyroid blood supply was important. Like I had 3 questions on thyroid blood supply on like one of my exams. I didn't know. You'll cover it again in when you get to neuro because these are all like neuro arteries, but they're easy. Superior thyroid artery, inferior thyroid artery. I think the question's more so asked about like what were they branches of. So I always try to include that. So the superior thyroid artery branches off the external carotid, and then the inferior thyroid branches off of what's known as the thyrocervical trunk, which like branches off of the subclavian. This image I found, there's an artery called the thyroid IMA artery. This one, so I put this one's a hard maybe. I can't really find a source that claims that this artery is a real thing, and if it is, it's only in like 1% of people. So I think you're good with just superior and inferior, but I wanted to at least point it out. It's still a hard maybe, just from the literature. Another image of the thyroid, like where the thyroid gland is. Remember anatomy brain, so right gland, left gland, right side, left side. There's another term to know, so don't get it confused with infundibulum, with the stalk, the pituitary stalk. This is known as the isthmus, I don't even know. But it's just like basically where the 2 lobes connect. So they connect in this like center structure here that's called the isthmus. Okay. And you can kind of, I like this picture too because it kind of shows like all the muscles that are around. Like here's your SCM muscle. Here's like the trachea. It sits right on top of the trachea. So little things like that. All right, some histo. So some thyroid histo. They'll 100% ask about this because it's relevant to the whatchamacallit, hormones. So there's two main cells to know with the thyroid. One are known as thyroid follicular cells. So you can see here the follicular cells are like arranged in like a nice pretty circle. So those would be like these purple cells here. These are your follicular cells. These are the ones secreting your thyroid hormones, so T3 and T4. Those guys are secreting that. Then you have just around the follicular cells, they're called parafollicular cells, right? So para, it just means around. So they're around the follicular cells. Another name for them is C cells. And the reason they're called C cells sometimes is that they secrete calcitonin. Calcitonin starts with a C. So it's kind of a little more creative, I guess. But so those are just kind of like located like randomly like next. I don't think they'll ever have you like have to pick it out of a slide, but I just wanted to show you the follicular cells are making the circle, and then the C cells or the parafollicular are just kind of like scattered through them. And then inside the thyroid, this is very characteristic for thyroid tissue, and this is really important for when you start getting to like thyroid cancers. I actually didn't notice if there was thyroid cancers on your syllabus, but whenever you get to thyroid cancers, they will just show you slides, and it'll be like, what type of cancer is this? Thyroid cancers are really easy to tell because they have this colloid in the middle, and this is like very, again, very characteristic for thyroid, just thyroid tissue in general. Okay, it doesn't really do anything, it's just kind of there, but it's a good marker. It's like a good way to be like, okay, that's the thyroid. Okay, so follicular, T3, T4, parafollicular, or C cells, calcitonin, which regulates calcium. Your parathyroid glands, so these are going to be the ones that are located on the back of your thyroid. So see this? There's 4 of them, and they're located at like the corners of your thyroid. They're embedded. So, and this is like a very, like, it's hard to kind of show you without showing you the gland in like, gross anatomy. I tried to find a really good gross anatomy picture. I couldn't. So I was like, whatever. They're embedded. So you can imagine, and I think I put it on the next slides. We'll talk about it, but you can see like they're literally embedded just like in the thyroid on the back. These guys secrete PTH, parathyroid hormone, which is also important for calcium regulation. And then these get supplied by the inferior thyroid artery. So you can see down here, here's your parathyroid glands, and then the inferior thyroid artery is going to supply those. So it's supplying just like the the bottom part of the thyroid gland, and then it's also going to supply all of the parathyroid arteries. No, parathyroid glands. And the inferior thyroid is a branch of the subclavian artery. All right, so here's my pro tip. So if you look at that picture and you see how tiny the parathyroid glands are, also remember, I'm going to talk about this a little bit more with Repro, but remember that in the real world, things aren't color coded. So you can imagine if this was all the same color, and let's say this patient has a thyroid tumor and the tumor is growing like right here. If you're the surgeon, you're going to be like, okay, like I want to get the tumor out. I'm not really so much concerned about anything else other than getting the tumor out. Sometimes you can just straight up take out one of the parathyroid glands. Again, they're just kind of there. I mean, you can probably tell there's a little difference, but they're not concerned about it. They're trying to get out this tumor. So I put on here, like a lot of the times, like in vignettes, it'll say like, someone has a thyroid tumor and now they're having symptoms of hypoparathyroidism. So like low calcium, for example, and other things. I didn't want to go into it too much because that's more of like a physio thing you'll cover. But they'll present with these symptoms of the hypoparathyroid, like that are, you know what I mean? Like it was a thyroid tumor. Now they're presenting with hypoparathyroid syndromes. And you're like, wait, why? And they won't tell you this in the vignette, but you have to almost assume like, oh, there's a thyroid tumor. Like, oh, they definitely got their parathyroid glands accidentally taken out. And I think my first year we had a case where that's what happened, and it drove my group crazy because we had no idea. We were like, what is going on with this patient? Like, we could not figure out why this patient was having their symptoms. And then we're like, oh, it's probably got his his hypoparathyroid glands taken. No, sorry, his parathyroid glands taken out accidentally, and that ended up being what happened. So it's just something to look for. Again, anytime I can do that, I'll throw it in there. Okay, so the adrenal glands. So the adrenal glands, another name for these, are suprarenal because supra just means above. They sit right on top of the kidneys, right? So above the kidneys. So you can see a picture here. They are comprised of outer cortex and inner medulla. So again, very similar to the kidneys, right? Remember the kidneys had an outer cortex, inner medulla. For the adrenal glands, the cortex is producing steroid hormones, and then your medulla is producing catecholamines. So remember, we did briefly touch on catecholamines. Those are like epinephrine and norepinephrine are examples of catecholamines, okay? Remember they're retroperitoneal. I didn't put my little retroperitoneal slide in here. I should have, but they are retroperitoneal organs. I think they might be the A and no, they're one of the letters in SAD puckers. I forget which ones they are because I don't know if they're adrenal or suprarenal. Thank you. They're the S, and I think it's probably the suprarenal glands in SAD puckers. So they are the S. They're retroperitoneal. And a fun fact, because I just think it's fun, is the medulla. So only the medulla, not the cortex. So just the inner part of the adrenal gland is derived from neural crest cells. So you guys briefly touched on neural crest cells with Hirschsprung's last block. So it's making a comeback. So it's, again, kind of cool that you have like this endocrine organ that's derived from like a neural, like it has like a neural root, basically. And this will become relevant eventually, which you'll cover. Here's the blood supply. The superior, medial, and inferior suprarenal arteries, which are all on here. I should have boxed them, but it's okay. They're just all like over here. So your suprarenal arteries, you have left and right sides. All right, so histos probably this is the most high yield probably for is this one because they will straight up. I'll show you. I actually found a picture that was literally on like every exam I've taken because they like to ask about these zones. So the cortex, and I want to point out I'm only talking about the cortex. I'm not talking about the medulla. I'm not talking about that outer capsule. Just the cortex. Okay. So the cortex it has this capsule, and then there's three main zones. So the first zone is the zona glomerulosa. So that's going to be the outermost just below the capsule. Then there's the zona fasciculata, which is going to be the middle, and then the zona reticularis, which is the innermost. So outermost means it's like closest to the capsule. Innermost means it's closest to the medulla, because then after the cortex, it switches to the medulla, right? And then these are important because these are the sites of your various steroids. So and each zone produces a different type of steroid. Okay, so the zona glomerulosa produces, I should have put the other name for this, mineralocorticoids. It's a word. That's a word. So mineralocorticoids technically contain, include things that aren't aldosterone, but honestly, if you see mineralocorticoids and aldosterone, they're interchangeable. Okay, so aldosterone is the major mineralocorticoid, and sometimes they just call, they're trying to talk about aldosterone, but they just say mineralocorticoids. It's fine. Okay, so technically, not really aldosterone. It's like technically mineralocorticoids, but they're like the same thing. Aldosterone is the most like clinically relevant one. The fasciculatus produces glucocorticoids, and the most important one is cortisol. And then your zona reticularis is going to produce your sex hormones, specifically the androgens. So again, we're talking about steroids, so think like testosterone. There's very little estrogen, that gets produced by this zona reticularis. I mean, obviously in females, most estrogen gets produced by the ovaries. If you didn't know that, it's fine because you're in Repro block, right? But most of the testosterone gets produced in the testes, and most of the estrogen gets produced in the ovaries. But there are, and this is in all people, some of both that get produced in the adrenal cortex. So it's just something to keep in mind. This is really important to know for when you're doing like congenital adrenal hyperplasias. So CAHs, that's probably the most high yield pathology for endo block. Congenital adrenal hyperplasias, and if you understand that there are testosterone gets produced, can get produced in higher quantities in this zone, some of the symptoms will make sense. You'll have female babies looking more like males because they're starting to get more testosterone than they should get because they're having a pathology state where they're producing too much testosterone specifically from this zone. Okay, it's not like they have testes now. It's just like this zone is hyperactive and it's making more androgens. Okay. So how a lot of people in my year remembered this, like these three zones in this order, was GFR. So from the outermost layer to the innermost layer, it's GFR. Whatever works for you, but you should know this order and what they produce. So here's a picture of this. So again, we're only talking about the cortex. So remember the capsule's on the most outside, then you have those three layers in the cortex, and then the medulla's in here. And I have this image here. I think I blew it up. Yeah. So a lot of the times you'll see this. You should 100% know this, and we'll talk about it. So I would almost bet money that you will get a slide showing just a histo slide of this, and then they're gonna be like, oh, where's aldosterone made? And you have to just point. It's A, B, C, D. And it's oh God. So whenever they do something like this, I put the descriptions of how they'll describe the cells in these boxes, but I don't think they'll switch. I genuinely don't think they would rotate this and flip it. I just don't think they do that. But if worst case, look how big the zona reticularis is. So the zona reticularis is huge. And the zona fasciculata, another telltale with that is the zona fasciculata. It has these cells look very white and empty. I don't know if you'll learn about that in this year or next year with the path, but they do have a lot of glycogen stored here, so they're a little bit bigger. Because again, this is your cortisol. This is your glucocorticoid, so they have glycogen stores in here, which makes them look a little whiter. Again, do not think they would flip this upside down, but definitely know like your first layer is going to be the capsule. So if you look at this as like 5 layers, it usually is always going to be your capsules at the top. Then your zona glomerulosa is like the smaller layer here. It's really thin. When you start getting those like bigger whiter looking cells, that's your fasciculata. That's your cortisol. And then the very big layer is your reticularis, and then at that's your cortex, and then the very bottom is going to be your medulla, which we're going to talk about next. But this is made up of what's known as chromaffin cells. Okay. Okay, and then for the adrenal medulla, they're like I just said, they're chromaffin cells, but again, remember the adrenal medulla is derived from neural crest cells. So we're going to kind of have a similar thing that with the neurohypophysis, with the posterior pituitary, where it's going to sound very neuro-y. So, for example, the medulla is surrounded by the adrenal cortex and is made up of modified sympathetic postganglionic neurons. And this is the same as like what you guys learned, what we did at the very end of like when we talked about OMM for GI, and we talked about like, oh, sympathetic postganglionic neurons, you know, T whatever to T whatever, T9 to T10, whatever, T1 to 5, all that, no, 5 to 9, I think. All those things. So those sympathetic postganglionic neurons are primarily what make up the adrenal medulla. Okay, so they're all in there. Those modified sympathetic postganglionic neurons are called chromaffin cells. So these are sympathetic postganglionic neurons, and they just gave them a name because now they're in the adrenal medulla, and they just live there. So they're large, irregularly shaped cells, and they have many secretory granules for catecholamine storage. So they store your norepinephrine and your epinephrine. And like I said here, basically modified sympathetic neurons. And I keep emphasizing sympathetic for the clinical correlation, which we'll talk about in the next slide. But the location, they are arranged in clusters, and they tend to group around capillaries. And the reason why is because they're, again, neurons. They need blood. They need oxygen. So they tend to be around wherever there's blood, there's oxygen. So here is going to be your favorite pathology. This should be on everyone's LI list for like every case in endo. We loved having this on, not LI or differential. We loved putting this on the differential just to say the word. So this is a pheochromocytoma. And a pheochromocytoma is basically an adrenal medulla tumor. So a chromaffin cell tumor is a pheochromocytoma. And why I kept emphasizing that chromaffin cells are basically just sympathetic neurons, the symptoms of a pheochromocytoma is just catecholamine excess, is epinephrine, norepinephrine excess. So think about someone that's hot, they're excessively sweating, they have hypertension, they have a rapid heartbeat, they have a headache, they're short of breath. Just think of someone that just like exercised for 3 hours. Yeah, that's like a but they're just sitting there and then this happens. That's a pheochromocytoma. Yeah, that's pretty much what I want to mention. But on here you can kind of see, like, again, I don't think they would ask you like with the cortex to like pick out the chromaffin cells, but these are your chromaffin cells. They're just sympathetic neurons. Okay. Yeah. And sometimes they will ask like, oh, like pheochromocytomas arise from chromaffin cells, but what's like the embryologic origin? And that's going to be your neural crest cells, right? Oops. Because remember, neural crest cells are the ones that are actually giving rise, which that was my fun fact, right? Yeah. So the medulla is derived from neural crest cells, so they can tie this into embryo. They really do like asking about pheochromocytomas. So yeah, have fun with it. It's a fun one to say. It's like craniopharyngioma, pheochromocytoma. It starts getting into all the crazy names. All right, endocrine pancreas. So I didn't go into too much detail because we did the exocrine pancreas, right, with GI. So here is my little, I'm not going to waste time, again, going over pancreas anatomy because we can talk about new stuff. So if you want to review pancreas anatomy, so blood supply, like the head, the neck, the tail, all that jazz, that's going to be the same because it's the same organ. In the GI folder on the drive in the anatomy and blood supply video at roughly 138-37, you can kind of, that's like roughly where it is. You can kind of like piece through it to find like the blood supply discussion about like the head, neck, tail, all that stuff, and like where it is. Remember, it's a foregut organ, so it's going to be located a little bit higher up. Yeah, but so we kind of went into a little bit more detail with the exocrine pancreas with GI, because remember, exocrine pancreas, that's going to be like your acinar cells. They're secreting the digestive enzymes and the whatever, blah, blah, blah. This is your endocrine pancreas. So oh yeah, I put this in. All right. So I just wanted, pancreas blood supply is important. So this is from the video, the GI video, but I just put it on here again. Remember, the head and neck are superior pancreatico-duodenal branches, and those are branches of your gastroduodenal artery. And then the inferior pancreoduodenal branches, which is a branch from the superior mesenteric artery. And then the body and tail kind of are branches of the splenic artery, which itself is a branch of the celiac trunk. GI blood supply never goes away. Okay, so we talked about this, like pretty much this part in GI. So the digestive enzymes, your ampulla of Vater, sphincter of Oddi, blah, all that fun stuff. This block, which we're going to talk about, is your endocrine pancreas. So hormones that are secreted by the pancreas, they're going to be located in what's known as pancreatic like islets, or you can see them called like islets of Langerhans. So islet of Langerhans, it's the same thing. They look like, I guess, little flowers on here. It's kind of cute. So these are little islet of Langerhans. And if you zoom in on them, there's three, I think they only show two, but there's three main cells to know. So I have this picture. And the three main cells to know within an islet of Langerhans is alpha cells, beta cells, and delta cells. So your alpha cells are in green. So that's going to be everything in green here. Your beta cells are in yellow, and they're going to be secreting insulin as well as, all right, we didn't talk about that yet. So alpha cells, beta cells, and then delta cells are in pink. So I tried to color code so you can see like an islet of Langerhans is like primarily just a bunch of these cells. Your alpha, you shouldn't 100% know which cell secretes what. And the reason I'll say like you should definitely know this is because I don't know, I forgot to look if this is on your syllabus, but definitely second year, there are pancreatic endocrine tumors. So not like pancreatic, like you have a pancreatic tumor, like, or you have pancreatic cancer and like, the survival rate with that is like 1%. You can have a pancreatic tumor, which is one of these cells, spases, which is now a different type of tumor. It's called like a pancreatic endocrine tumor. That is going to be like, you can have an alpha cell tumor, you can have a beta cell tumor. I don't know if you can have a delta cell tumor. I'm assuming you can. But the symptoms of these tumors are going to be overexpression of whatever hormone it normally produces. So for example, if you have an alpha cell tumor, you're going to get symptoms that, just imagine having way too much glucagon, which, remember, glucagon raises glucose. So you're going to have symptoms of like basically diabetes, basically, with an alpha cell tumor. Which again, I don't know if you have to know that. This, you'll definitely cover it second year, but I don't, just look on if you have to know that. But regardless, know that alpha cells secrete glucagon, beta cells secrete insulin, as well as C-peptide. This is like I should have put a slide on this. It's like another like fan favorite in vignettes. So sometimes they'll talk about like nurses, or they'll mention someone in healthcare because they want you guys to think like, oh, this person has access to medication. So they'll say like, oh, like there's a nurse or a doctor or even like I don't know, whoever, like someone in the hospital, like an MA, someone has access to medication, and they're having these symptoms of, basically it seems like too much insulin, like way too much insulin. So glucose is super low, they're passing out all the time, and you're like, that's super weird. And typically they'll ask like, how do you know that this patient isn't just stealing insulin from the hospital and injecting themselves with insulin? Which is a psych thing. It is a psych thing. It's, people do it. And one of the main ways you can tell is you test for C-peptide. So if this person has like, let's say an insulinoma or a beta, which is a beta cell tumor, right? So if they have an insulinoma or a beta cell tumor, beta cells make both insulin and C-peptide. So you'll see elevated levels of insulin and you'll see elevated levels of C-peptide. Both are made by these beta cells. If you have someone that's just injecting themselves with insulin for, whatever reason, for this psychiatric disorder they have, or again, whatever, you'll cover it in psych. I forget what it's called, but it's like you're trying to make yourself sick for attention. You test them for C-peptide and there isn't elevated levels of C-peptide. There's only elevated levels of insulin. So that's usually like how it's like asking, again, it's like an anatomy physio question. Like, do you know that beta cells make C-peptide, and like just injecting insulin, you're not injecting C-peptide. Okay, little plugs. And then the delta cells, these make somatostatin. And remember, somatostatin just like shuts off every single thing. So you can have delta cell tumors, you can have somatostatinomas, and that's just what they're referencing. All right. So I put some questions in here. Endo anatomy questions are really hard to come by. So I really only found two, but we can do them. I think we should do them now and then switch gears. I'm going to expand the image in like a second. Well, in like 30 seconds, maybe. Okay, I'm gonna zoom in on the image. Okay, all right, let me go back. All right. Okay. So, like I said, endoanatomy questions are really hard to come by, but you're 100% going to get a question like this. So, this is a little bit more board style than what you'll probably get on your exam. They will probably just ask you like, "Oh, which one's the zona reticularis?" But this is like a good, we did talk about ACE inhibitors and angiotensin 2 a little bit. So even if you didn't know and you're just like, "Oh, I'll just pick one." Um, this answer is going to be, oops, it's not A, it's B. Oh my gosh. Okay. Sorry, everyone. So this is actually B. Ignore me with A. Because this is asking about, this is basically the zona glomerulosa, right? So this is the one that's producing aldosterone. So if you don't have angiotensin 2, you don't have aldosterone, and then you're going to have decreased activity of the zona glomerulosa. So again, going through these layers, remember A, actually, let me go back here. A is going to be the capsule. So remember, if you always think of it in, yeah, sorry guys, sorry. I put these questions in late last night, so you know. But if you think of this as like groups of 5, and this is actually really nice of this to like give you little dividers, because I think this is a really hard one to like be like, I'm like, where are all the cells? Like I don't even know where all the cells are, because it can vary, and I'm like, none of these look like, like big cells. So I'm like, oh God. So A is gonna be the capsule always. So it's always going to be the capsule. B is your glomerulosa, C is fasciculata, D is reticularis, and then E down here is going to be the medulla. Classically, what people do sometimes, like me probably last night, super late, is they're like, oh, the first layer, oh, like that's the first layer, right? So that's the zona glomerulosa. And they'll pick A, which no, it's B. It's the it's B. Please just ignore me. I have the correct answer here and everything. But yeah, so that's kind of like this is a very board style question, but I really liked it. We have talked about ACE inhibitors in the past, but okay, cool. Okay, and then the next one. All right, anyone that wants to answer? All right, cool. So everyone that sent to me, awesome. You all got it right. This is norepinephrine. So this one's actually correct. This one's actually A. So we talked about clusters of chromaffin cells. That's going to be in the adrenal medulla. Remember, they secrete epinephrine and norepinephrine. So a question, what is, oh God, dehydroepiandrosterone? There's variations of like testosterone and your androgens. I'm pretty sure this, let me triple check. Yes, so it is an androgen. So So there's like weird androgens that get secreted by the zona reticularis. You'll learn about some. Costanzo covers some of them. I think it's a little. I actually think she talks about them when she talks about congenital adrenal hyperplasias, because she does talk about them. Um, so this was if I saw this, I'd be like, oh, it's like one of those weird androgens that gets secreted. This isn't one of the ones that you should know. I just again from my experience, but just seeing it, I'm like, yeah, that's a weird androgen because there's just weird ones that get produced. Okay. All right. Look at that. Okay. So switching gears to repro anatomy. We covered actually a solid amount of this already. I'm going to preface this though. We're going to start with male repro anatomy because I think it's harder than females. No, sorry. I think it's easier than female repro anatomy. Whew. I definitely put on here like things 100% you will be asked. So even if it didn't show up on the, and I keep saying that as if like I know, but it's like you'll be asked it. So I remember my exam, we had like four of the same question, and it just kept getting asked. So we're like, okay, we get it. It's an important concept. So we're gonna start with this one. No, male repro anatomy is definitely easier than female, so we're gonna start with it. But some of this stuff I have put in previous PowerPoints and previous things that we've talked about. Okay, so it's just gonna be like a refresher. And the first one is gonna be what I talked about a ton in renal, because it's so important, is the drainage. So the drainage of the testicles. So I know I don't have like a picture of the anatomy right off the bat, but these are the testicles. And then always remember your anatomy brain. So right side, left side. And I did kind of briefly talk about what the pampiniform plexus was, but now it's like you actually have to know what it is. And it's basically just the series of veins that drains the testicles on each side. Okay. And they do look kind of weird. They look squiggly like this. And that's important. We'll talk about why that's important, because these can get engorged in certain pathology states. All right. So we have venous drainage that's going up. And then on the left side, it's going to go up the gonadal vein, and then it connects with the left renal vein. So it connects here. Then from the left renal vein, it drains into the inferior vena cava. On the right side, we have testicle, we have pampiniform plexus, and then we have the right gonadal vein that goes directly into the inferior vena cava. So like what we talked about with renal is like, let's say you have a renal tumor or something that's blocking the renal vein on the left side, you're gonna get backup on just the left side. That's called a varicocele. We'll talk about that. I have a slide on that. You're gonna get a question on varicocele, 100%. And the question will be like, what side is it more common on? Yes, good question. So can nutcracker syndrome occur too? 100%. So if you guys remember, I don't think I have a slide on nutcracker syndrome in this PowerPoint, but from the renal, somewhere in the renal lecture, like the anatomy lecture for renal, I talk about nutcracker syndrome. It's the exact same pathology state where you get, and it's usually not a tumor. It's more so like an SMA type syndrome, where remember the SMA can come down the SMA artery, so the superior mesenteric artery. We talked about SMA syndrome in GI. That's when it crushes on the duodenum and it causes GI issues. SMA syndrome can also block the left renal vein. It can also come down on this guy, and then you can also get a varicocele, and you can get nutcracker syndrome. Nutcracker syndrome is pretty much when the exact same thing happens, but now you also have like it's like you get flank pain, you get hematuria, you get all sorts of like additional things with nutcracker syndrome. I think with the nutcracker syndrome, it's kind of gross, but it's like the hematuria is like, oh, it's like the nutcracker, like, sorry, but like that's like officially when it becomes like nutcracker syndrome, is when you get that blood in the urine. Okay, versus something like varicocele, it's just the engorgement of the pampiniform plexus, because now it's like all the blood is just rushing back down because it can't get drained. Okay, so you'll definitely get asked this. So remember the left, so you're more likely to see a varicocele on the left side because it drains into the left renal vein first. The right gonadal vein does not drain into the right renal vein first. It goes directly into the inferior vena cava. So here is just another picture of this. If you're new to my slides, remember that this is, like when you see these numbers on it, this is from like the high yields PowerPoint that everyone uses to study anatomy for boards. And it's like all the anatomy you need to know from boards is on this PowerPoint. So whenever I find it relevant, I put it in the first, like your guys' slides, because it's never too early, right, to like learn board style anatomy, which is anatomy. Okay. So anyway, here is like now looking at the body. So here's your inferior vena cava on the right side, and then here's your, your aorta on the left side. And right here, this is going to be a right renal vein. It's a lot shorter than the left renal vein because the left renal vein has to course across the aorta, and see how it goes under the SMA as well. So that's why you can get nutcracker syndrome, you can get varicocele. But then I have here, it's longer, and it's joined by both the suprarenal. So the suprarenal vein drains the adrenal gland, right? And it's also connected with it's also connected by the left gonadal vein here. And then they all go into the IVC together. The right gonadal vein just goes directly in. All right, so here's varicocele. Yeah, we're gonna start doing pictures, so it's happening. So remember, like I said, varicocele is engorgement of the veins of the pampiniform plexus. So remember I said they look kind of like, that's kind of how they look. So you can imagine when they engorge, the classic like buzzword for this is there's like a worm-like scrotal mass, or there's like a oh, you're in public. You're in for a treat with these next few slides. I'm excited for you. Okay. So you'll see like, oh, a bag of worms appearance, or oh, there's a worm-like scrotal mass. They're talking about a varicocele because that's like classically how they'll describe like the pampiniform plexus like engorging with blood. Okay. And like I said, formation is always on the left side, because again, anything that can block the left renal vein can now cause a backup, versus the right. It's a lot harder to like block off the entire inferior vena cava. Not saying it's not possible. Like you can have like a tumor right here and just a really well-placed IVC tumor, but it's like, that's like very not common. Versus like up here, you can have tons of things like just blocking this, and then you're going to get it secondhand. All right. So then other things that they'll talk about, because they know that this is it's, if they say bag of worms, like, you know that this is going to be a varicocele. So some other things that they'll talk about in a vignette is they'll talk about transillumination. So transillumination basically means the doctor has like a flashlight or something, and they stick it up to the scrotum. Like they'll stick this flashlight up to the scrotum and see if the light can pass through it. And it'll make more sense when we talk about a hydrocele next. But there's no fluid in there, right? Like you have this scrotal enlargement, and it's like, is this fluid? Is like, what is it? A tumor? Like, what is it? So if we have a solid mass, like engorged veins, like that's a solid thing. It's not gonna be able to get, the light's not gonna be able to pass through. So they say like there's no transillumination. Hydrocele, which again is just all water in there, enlarging the scrotal sac, that you will see transillumination. So again, that's like a difference between varicocele, hydrocele. And then the other thing too is that since like the left gonadal vein is connected to the left renal vein, which is connected to the IVC, like since all these veins are connected, when you do Valsalva, so imagine doing Valsalva. So Valsalva, like when you cough, that's Valsalva. When you try to blow, like if you put a pen in your mouth and try to blow, that's like how they'll do Valsalva in the hospital. Or like they'll give a patient a syringe and tell the patient to try and blow the syringe. They're trying to mimic Valsalva. And with Valsalva, you'll actually see these veins, like these strands, increase in size. Because again, you're increasing that intra-abdominal pressure, and it's going to go back even more. So it's like another way to be like, oh, these are veins, right? So it's just other ways to kind of help you identify that this is a varicocele, because now you have veins getting bigger with Valsalva, which is like, okay, yeah, that's because it's connected. Why does a competitive gymnast not get her period anymore? We'll talk about that later. Actually, I don't want to tell you about it because you'll get a case on it, 100%. But if you don't, we can talk about it, I promise. All right, I'll just tell you. So basically, it's when anytime, and this isn't just a competitive gymnast, it's any competitive athlete. If you are not like eating food, and this can also happen in people that are anorexic. Yeah, so it kind of has to do with fat stores. It also has to kind of do with, like basically if the body thinks you're not taking care of yourself, it'll be like, yeah, you can't have a child. Like I will not allow you to get pregnant. So you don't secrete FSH and LH, which females need to ovulate and whatnot. And you'll learn about all that. Yeah, it's literally, stress. Yep. That's why like how stress can delay your period. It's because like the body's like, you cannot have a child in these conditions type of thing. Our bodies are insane. Like they're actually insane. So they call it functional hypothalamic amenorrhea because it's like the hypothalamus is deciding you are not fit to have a child in these conditions. So typically, again, it's always competitive gymnast, or it's like a track star, and or like someone that's anorexic, they just won't get their period. So a lot of the times, and you'll do this with Repro, like you'll learn about like primary amenorrhea versus like another cause of amenorrhea, such as this. And you have to work it up. You're like, why are you not getting your period? Like, what's going on? Do you have a genetic disease? Like, what's happening? So a lot of the times, like that's a good way to tell that this is like just a functional hypothalamic amenorrhea, because the body's like, yeah, you can't get pregnant. There's just not. It really doesn't have anything to do with weight. So another person had mentioned like, oh, low fat stores. 100%, because fat actually, like the more fat you have, the more estrogen you actually make, which you will learn in this block. I think they talk about that, how fat, like adipose tissue, can secrete estrogen. But it's more so like the hypothalamus decides this body is not fit, because it's like a lot of the times too, and that's why I mentioned like a competitive gymnast or someone that's fit but not necessarily like anorexic, because it's like they can still be fit, but it's like they're killing their bodies. They're working out 3 times a day. They might not be eating like very nutritious things because they're trying to stay lean. That's why a gymnast is a good one, because again, gymnasts are competing and whatever. But that's like usually how they'll talk about this, is because they're trying to get you to think of someone that is probably not taking care of their body enough. So the body's like, yeah, you can't take care of a child. Like the body's like, I won't be able to support this child if you have this child. So it's really interesting. You'll start like learning about how just freaking smart the body is. But yeah, that's one of the most wildest things. So if you see that though in a vignette, like a competitive gymnast, a dancer, sometimes, oh yeah, they'll talk about dancers, gymnasts, track stars, whatever. Again, people aren't automatically thinking that, because it's like that's not my first thought, is like, oh, they're anorexic. Like that's not my first thought with like I hear someone's like very fit, but it can still happen. Like it can still happen. So it might have a little bit to do with like fat stores and stuff, but it's more so like the hypothalamus decides like, no, not allowing you to even like ovulate. Like I'm not even going to allow you to ovulate. And that's again why they call it like functional hypothalamic amenorrhea. Interesting stuff. Sorry, little sidetrack with this lovely image on the screen, but okay. So does that make sense with varicocele? Okay, varicocele. You'll get a question on varicocele. So this was actually this is like where just words start getting insane. So I have this slide actually on when I talked about inguinal hernias, and I have a slide at the very end of this PowerPoint saying if you didn't watch inguinal hernias, which I don't even know if that was on your exam, but like technically it's GI, it will definitely be on this exam. So go through, like watch that part of that GI video and then do the associated hernia questions, because I didn't put anything about hernias in this PowerPoint at all. But it's very, very like repro anatomy focused. But in that PowerPoint, I talked about the processus vaginalis. So the processus vaginalis, and kind of how I explained it in the video, is when we're developing, remember this is us in utero developing. Remember we're a series of like tubes, right? So for just lack of a better word here. So here is the tube, and so when we are, more so developing now, and now like things are starting to go into place, we don't need like the peritoneal cavity, which is the GI tract, to be connected anymore, which is like here. We don't need that to be connected anymore with like what's down here, like where the testicles are going to be. So it obliterates the tract in between, like where the peritoneal cavity is and where the testicles will eventually be, which is the scrotal sac. That little tract should obliterate. So over here in this first image, this is your normal inguinoscrotal anatomy. All right. So this is the peritoneal cavity here. So peritoneal. And here's your scrotum here. And see how this is like it's like how they're trying to show a ligament. So this obliterated, it went away. So now it's just a ligament. This is normal. This in utero, like what this ligament was, is called the processus vaginalis, which is best seen in this image, which connects the peritoneal cavity up here to the scrotal sac. So you can see if you just get peritoneal fluid, so again, imagine any fluid just in the peritoneal cavity, even if it's just like, like just water or whatever, like whatever's there, it can now go into the scrotal sac, and then you'll get increased size of your scrotal sac. That's called a hydrocele, which we'll talk about. But it has to do with this processus vaginalis, because if this processus vaginalis doesn't, and this is what it's called, the processus vaginalis in utero, it should obliterate. But if it does not obliterate and it stays open, that can cause a hydrocele. Okay. It can also, it's actually really, really common to cause an indirect inguinal hernia, which I have down here. And that's what this is showing, which you'll see in that PowerPoint where I talk about the indirect inguinal hernias. But all it is your intestines now are able to go through, herniate through where the processus vaginalis is. And now you have like bowel in the scrotal sac. And that's an indirect inguinal hernia. So that's what the processus vaginalis is normally in utero. If it doesn't obliterate, it causes it increases likeliness that you'll get either an indirect inguinal hernia or a hydrocele. Okay? So all of that to say the peritoneal tunnel through which the testes migrate from the retroperitoneum towards the scrotum. Oh yeah, that's another thing you'll probably cover at some point. You know when it's like people's testicles drop or the balls drop, right? They literally migrate from up in the abdomen down. Like they migrate. And then when that happens, when they migrate down, it's called, ridiculous word, it's called the gubernaculum. Yeah. So the gubernaculum is basically like, I don't even really know what it is, but it's basically like, think of it as like it's pulling down. It's not on any of these images, so I can't show you, but it's basically pulling down the testicles, helping it drop, basically. So that's what allows now the testicles to go from where the abdominal cavity is down to now where the scrotal sac is. That's called the gubernaculum, and it goes through where the processus vaginalis is. And then after that testicular descent, it should obliterate. If it doesn't, and we've talked about what happens if it doesn't obliterate. So that's the processus vaginalis. So I want to talk about a hydrocele because this can be commonly associated with a varicocele, but there are some differences. So with a hydrocele, this is your persistent processus vaginalis. And then the remaining portion is going to make what's known as the tunica vaginalis. And what I mean by that is this is the normal over here. So normal. Here is the peritoneal cavity. The processus vaginalis obliterated, but in utero, it went all the way around, right? Because it goes all the way around the testicles. And when it obliterates, now it's called the tunica vaginalis. Okay, so it's just another anatomy term. Tunica vaginalis is just tunica means coat. I don't know if you guys remember that from what is it? The artery, like when we talked about vessels, and I talked about, the tunica intima, whatever. Tunica just means coat. So whenever you hear the word tunica, and I mention it because I'm going to talk about some of these coats in future anatomy. So whenever you see that, just think of it as it's like surrounding something, like you put a coat on, it's surrounding it. So the tunica vaginalis, which is kind of annoying, it's called vaginalis, but it's surrounding the scrotum. Well, it's surrounding the testicles in the scrotal sac. Okay? And that's after the processus vaginalis obliterates. Okay, so again, usually hydroceles are going to be in children, like I have here, but they can present in like young adults. They can. I'll take that with a grain of salt. I have seen questions with like 20-year-olds with hydroceles, so it's like, this is an image of a child because this is like usually more common in children, because again, it's going to be before the testicular descent. So this is what it looks like. So again, if you're like a doctor and you're like, I just can't tell, is that a varicocele, is that a hydrocele? Get a flashlight, shine it up to it. Now this is basically just like a sack of water, as you can see in this image. So if you shine a flashlight to it, it'll go right through because again, it's water. So that's what it means by like there is transillumination or there's no transillumination with a varicocele. This will also bulge with Valsalva because again, now we're connecting the peritoneal cavity to this, like just think of this image. You're connecting the peritoneal cavity up here, which again, with Valsalva, you're increasing intraperitoneal pressure. So you increase the pressure here, it's going to go down here, and then it's going to go down here. So it's not really veins. It's a little bit different from veins, like with varicocele, but you'll still see a bulge with Valsalva here. So you'll at least know that there's a connection with the abdominal cavity. Okay, so this is where it gets kind of, they love this kind of stuff. So the cross-section of a penis. So what they're going to ask you, and this is kind of where I tried to give you like the view that you're going to see. And I was asked this question on exams and on both sets of boards. They love this. I'll actually tell what I did with male anatomy was like everything that they will 100% ask you in terms of like what you need to know from male anatomy. This is one of them. So I put the definitions of what things are right next to them. So the first one is going to be the tunica albuginea. And again, this is a cross section. So again, imagine it's just like a straight slice through, down and through, and then you look down it. So the tunica albuginea, remember, tunica means coat, so it's surrounding something. The albuginea surrounds what's known as the corpus cavernosum, which is in pink on both sides, and then the corpus spongiosum down here. Okay? So tunica albuginea is this yellow, and it's surrounding the cavernosa and the spongiosa. The corpus cavernosa, so that's what this pink is. This is erectile tissue. Okay, so this is what engorges during an erection. And the classic question, and it gets everyone, it always gets everyone, is sometimes they'll ask, like, is this an artery or a vein in here? Like, they'll ask, like, what is this in the corpus cavernosum? And it's an artery. Arteries are bringing blood. Like, that's how it engorges with blood, is with an artery. So, and again, it seems kind of like, you're like, oh, right? But it almost seems like it's too obvious that you're like, oh, maybe it's a vein. I don't know. But these are the arteries that are bringing the blood to like engorge this erectile tissue, this corpus cavernosum, okay? Down here, and then the other thing that they ask is like, what's in this? And yes, I know, it kind of looks like a face. It's like an alien, I think. So the two eyes of the alien face is the corpus cavernosum with arteries, with the arteries in the middle. Down here, this is the corpus spongiosum. This is not, this is erectile tissue, but this has nothing to do with an erection at all. Again, you can kind of note there's no artery in here. I'm going to get rid of my circles. So there's no artery in where the corpus spongiosum is. This is the urethra. So the whole point of what the corpus spongiosum is when you do get an erection and it engorges with blood, we don't want to crush the urethra. So the whole point of the corpus spongiosum is to just prevent the urethra from collapsing when these engorge with blood. Okay? Okay. And then these are like not as important in my opinion, like these dorsal guys up here. I will talk about, so there's a lot of fascia that's located here. So there's superficial and deep or buccal fascia. I'll talk about superficial and buccal fascia when I talk about penile injury, because sometimes they'll ask about like, oh, if you get in a car accident, what part of the male urethra is affected? And it actually has to do with buccal fascia and the superficial fascia. So we'll talk about that in a few slides. But everything else I don't think you really need to know. So corpus cavernosa, artery, tunica albuginea surrounds, corpus spongiosum, no artery, no vein, that's urethra, so urethra, and then it's also surrounded by tunica albuginea. Okay, so talking about, and again, these are all going to be from that high yield anatomy PowerPoint. They go through the 3 different parts of the male urethra. So the first part is the prostatic portion, which is just located where the prostate gland is. So this is the bladder. And then the first part is immediately after the bladder, like immediately after the urethra leaves the bladder and becomes the urethra. Here's the prostate gland on both sides. So X here, X here. And again, this is a cross section. So they cut this down. So that's why it looks like there's 2 prostate glands, but it's just one that surrounds it and they just cut it. What's important about this portion is this is where the ejaculatory ducts open. You can see them right there. And then the prostate glands I don't think you can see them, but they also open here as well. Okay, so we have the ejaculatory ducts and we have the prostate gland openings in the prostatic portion. Briefly touching on the prostate gland because it will probably come up at some point, not in terms of like cancers probably, but the prostate gland, there's 5 lobes to it actually. I know this only looks like there's 2, but there's 5. The 2 main ones that I thought were at least important to know at this level, like right now, is the posterior lobe. This is going to be the lobe that enlarges with prostate cancer. So you can feel this on rectal exam because it's in the back. Okay, so that's the posterior lobe. The lateral lobes, so you have 2 lateral lobes, those are going to enlarge in what's in a condition called benign prostatic hyperplasia or BPH. That's just going to be like, it's kind of like people get, like older men get concerned that they have prostate cancer. Like they get concerned with this. because they're having to go to the bathroom a lot. They're kind of concerned, but it ends up just being BPH. And they can tell this because on rectal exam, they touch the posterior lobe and it feels completely normal. And there's obviously other tests that they can do, but it's because only the lateral lobes are enlarging in BPH. Okay. Yeah. Good. Okay. So yeah. So good question. What view is this image? Yeah, it's kind of hard to orient. So imagine that this is the bladder up here, and then this is going to be the urethra, and then it's going to kind of like, I think it's going to be like coming out towards you. So the prostate gland completely surrounds it. So we're probably seeing the two lateral lobes in this image, honestly. And then we're going to have like the anterior and the medial lobes are cut out, and the posterior lobe is going to be behind this. So the anus is going to be behind this image, if that helps. So we're looking kind of like at the front. Here's your pelvic bone, so your pubic, no, what's that called? Like up the AS, no, one of the hip bones are up here, and then down here this is going to be your oh my God, what are these things called? You guys know what I'm talking about, right? One of these is like the ASIS, and then the other hip bone down here. And yes, thank you. Oh my God, beautiful. Yes. So iliac crest is up here. Incredible. And then down here is going to be this is just the iliac crest, right? So here's the top part. Here's the bottom part. Yes. L4. Exactly. Okay. Okay. So I know it's kind of hard to orient yourself. Yeah. I'm sorry. Yeah, this is like the best I can do. Um, but if you look at like a side view, I wanted to spare you guys looking at like this from the side because it looks insane. It just like goes in like, it's like it doesn't look how you think it should look. So I didn't really want to confuse anyone. This is probably the best to see. Yeah, side view is extremely hard with the pelvic region. You're going to get kind of accustomed to it, maybe a little bit next year. But yeah, this is good for now. So bladder, it's where the bladder should be. And then the urethra, this is the prostatic portion. We're going to go through all the portions, but it's basically going to start coming out towards you. Oh. Oh, I did put a picture with all the lobes. All right. Yes. So you have your two lateral lobes. That's almost like that's probably what we're seeing in green. And then we have the anterior lobe here, median lobe, and then the posterior lobe somewhere down, all the way down here. That's your posterior lobe. So that would be, you can't see it in the image. And then the ejaculatory ducts, which go directly into the prostatic portion of the urethra. All right, cool. All right, here's side view. Oh, so here's the side view. Actually, this isn't as bad as I thought. But so see how here's the prostate gland, right? See how big the prostate gland is? So I think what we were looking at in the last image was right here, like a cross section from this side. If we were over here and we were looking this way onto it and they did a cross section this way. Okay, good. Oh, okay, that's good to know. Maybe I'll move this up. I'll move this up for future. Just to be like, hey, look at where we are, and then I'll start switching it around. So this is the rectum, and I just wanted to show you with this image too before we go into the other portion. Like if you were to do a rectal exam, just looking at this image, you would be able to feel the posterior lobe, which is like down here. You'd be able to feel the posterior lobe of the prostate gland. You would just go like that and feel it. So you can tell and again, that's typically what gets enlarged with prostate cancer. So if it feels normal, the patient likely has BPH. But again, there's other tests you run and whatnot. But okay, glad this makes sense. So bladder, we just did the prostatic portion of the urethra. Here's the prostate gland, here's the rectum. And now here is actually the pubic symphysis. So I know it kind of looks weird because it's a cross section across, but this is bone. So this is the pubic symphysis. There's some fat, some muscle, blah, blah, blah. All right. So the next portion is going to be the membranous portion. And I like this image too because this is the pubic tubercle, right? So this is going to be pubic tubercle, like pubic bone. One of the injuries that's like common, like that commonly happens with males when they get in like really intense car accidents is the pubic tubercle actually like goes back just because of such high pressure. So it goes towards the back and it ends up taking out the membranous urethra. And you actually have urethral injury from a car accident, a male getting in a car accident, which we'll talk about. I think I mentioned it at some point in a future slide, but that's why this little tiny membranous portion, which is super tiny, is relevant because it can get damaged in that type of injury. Other things that are relevant about this portion, so the membranous portion is going to be there's these glands called Cowper's glands. Cowper's glands are, the other name for it is bulbourethral glands. These are just glands that produce lubrication. There's a slide at the very end of this, and it's like one of the most annoying yet high yield slides to know. Is during embryonic development. It's like if you were going to be a girl, what parts of like the pelvis region do you get? If you're going to be a boy, what part of the pelvis region do you get? They call them analogs. They call them analogs. So it's like if you're a male, what's the female analog to that portion? If you're a female, what's the male homolog to that portion? So Cowper's glands is one of them. They line up. There's an analog on the female side as well. So again, just wanted to mention it. That's where they are. They're in this membranous portion of the urethra. Okay. And then the last portion, it's called the spongy portion. It is just the rest, basically just the rest. And you can notice here, if you take a cross section of the spongy portion of the urethra, it looks like our little alien face from earlier. So we have our two corpus cavernosas. We have our two arteries, which you can't really see in the middle as our eyeballs. And then you have your one corpus spongiosum, which has the urethra in it. So this urethra is the spongy portion of the urethra as soon as you see this type of cross section. So this is now going to pass through, it's going through the corpus spongiosum as we talked about, and then it's going to open at the external urethral orifice, which is the tip of what's known as the glans penis, which is at the very tip. Okay. Yeah, so here's another picture of the bulbourethral glands, which are also known as Cowper's glands. So this is still membranous, and then as soon as we get to like this portion, that's like one where it's considered spongy, the spongy portion of it. Okay, and then it goes all the way out. All right, this is what I was mentioning. So there's two types of urethral injuries, and this is kind of how they ask anatomy, I guess, with this type of stuff. These are directly from first aid. So there's two types of main injuries that the urethra can get. The first one is known as a straddle injury, which is when, like, let's say you're trying to climb a fence and you kind of miss your footing and you straddle that fence. That would be called anterior urethral injury, because notice, like, if you look at the whole urethra as a whole, it's like the anterior portion of it, which is mostly going to be spongy, right? So it's mostly going to be spongy. That's the last part all the way out. And again, just imagine, boom, straddling something and just like something perforates. So all this in orange is basically blood and urine mixing. Okay, so that's what that is. The other thing they can ask about it is like, where does blood accumulate? And it's going to accumulate into the scrotum. And then from the scrotum, it can go into the perineal space, which is just like surrounding, like perianal, right? So it's, I guess not anal. That's actually not a good analogy. But it's just everything that's surrounding like those outer fascial layers. So actually, I think, yeah, I did. Okay. So remember, I was like, oh, we'll talk about this fascia later. Notice how there's all this fascia. In a straddle injury, this Buck's fascia can rupture, I guess down closer to the urethra. It can rupture. And that's how you're able to basically think of blood accumulating around, because this is the deeper fascial layer. So just imagine, again, it's kind of like what's it called? Like when you get like cardiac tamponade, when you get just blood filling up in that cavity, it's just like filling up but it's still contained. It's kind of like the same thing here. This is filling up with blood and urine, but it's still contained because we punctured Buck's fascia, which is the deeper layer, and then everything can get in between. So that's why it accumulates in the perineal space, and that's why it also is accumulating into the scrotum. And then how this would present clinically, so how like a patient would come in, it would present as a scrotal hematoma. So a patient would come in, and again, it would look like that the patient had like their scrotum is enlarged, and the doctor would be like, yeah, you have a scrotal hematoma, and they would diagnose them with like a straddle injury. Versus something like a pelvic fracture, which again is going to be like very, very high speed car accident. It pushes this pelvic bone down. And remember, what was right behind the pelvic bone that we talked about, or the pubic bone, sorry, what was right behind that? It was the membranous portion of the urethra. Boom, just severs it. So that's going to sever it. So you're not really getting much happening up here. But what's going to happen is basically the retropubic space starts accumulating with blood. And retropubic is going to be behind the pubic bone. And you'll learn about this a little bit more in H&P. But there's a lot of like free space in this area. You can kind of see it a little bit here. Well, like, it doesn't really look like there's much free space, but basically it's like all of this area now starts filling with blood. So what they'll say is like, oh, it looks like the prostate is high riding because all this blood here, it basically like pushes the prostate up. So they'll say like, oh, it's a high riding prostate. Oops. Yeah. So it's not really like an anterior injury that you can see, so to speak, but that's why it's always good to like get looked at after like a car accident or something to make sure like something like this isn't happening. All right. So a little bit more about the male. So the male urethra has two sphincters. The female only has one. And I highlighted the internal urethral sphincter. This is the one that that males have that females don't have. The internal urethral sphincter is up here. It's basically going to be surrounded by smooth muscle because remember it's a sphincter. So it like controls opening and closing. So it's smooth muscle. This is innervated by the sympathetic nervous system. Then the external urethral sphincter, which is down here. Actually, I think there's three now that I think about it, because then you have this one out here. Well, all right, then this one down here. This one has skeletal muscle down here, and then this has somatic innervation. And we'll talk about innervation. I have a good way to remember it. Actually, I think it's on the next slide. So this is how people remember how like what's responsible for an erection, what's responsible, like what nervous system is responsible for an erection, what's responsible for emission, and what's responsible for expulsion. So this is this is a good way to remember it. You guys will thank me. So what people say is point, squeeze, and shoot. So for an erection, this is the parasympathetic nervous system is in charge. And specifically, it's the pelvic splanchnic nerves. And that's S2 to S4. Okay? So that's responsible for achieving an erection. Emission. So emission is going to be, if I go back here, I should have put this afterwards because we didn't talk about like the pathway of a sperm, basically, or pathway of semen during this process. But emission is basically when it now like enters where the urethra is. Now it's being emitted, right? So that's going to be up here at this internal sphincter here. So that's where it's going to be because those glands are located here, right in this prostatic portion. That's the emission portion. That's controlled by the sympathetic nervous system, and specifically it's your hypogastric sympathetic, like your postganglionic, right? Your hypogastric. So that's T11 to around L2. And then finally, expulsion is somatically innervated, and specifically it's the pudendal nerve. And expulsion is actually the final act, right? And what's interesting is the first two are going to be autonomic. So this is like you don't have control over this. Somatic you have control over. So it's kind of like you have autonomic and you have somatic innervation for this process. But yeah, they will ask this. So you're welcome for point, squeeze, and shoot. All right, more on this. So I don't want to go into this too much because I want to kind of quickly move on to females. And this is just straight memorization, but they will ask you. This you'll also get asked. Yeah, I really tried to only put on stuff that I'm like, you'll probably get asked that because they like to, this is how they ask anatomy with this stuff. They'll talk about lymphatic drainage. And the reason why is because there's just so many lymph nodes that drain just so many different portions of like both the male and female reproductive system. I would say the most important are the testes, like what drains the testes. It's the para-aortic lymph nodes. So that's going to be in light blue. Again, I tried to color code as much as possible. So the para-aortic is going to be in light blue. And how people would remember this is you can think of para-aortic as your penis anchors. The testes are the penis anchors. Use that if you like. But then other parts too. So the superior part of the bladder, this is going to be your external iliac nodes up here. What innervates your prostate and your corpus cavernosum is going to be, which is like all this and like this like brownish color, I guess, is going to be your internal iliacs. And then your scrotum and your distal anus. So everything pretty much on like the outside, like I would think very superficial, your superficial inguinal. And then the glans penis, which is at the very tip, is going to be the deep inguinal. And what's really cool, well, not cool, but like what's interesting about knowing like the lymphatic drainage for the male reproductive system is if you know all the analogs to the female, like, oh, the testes in the male are the ovaries in the female, the ovaries are also innervated or drained by the para-aortic. The glans penis in the male is the clitoris. In the female, that's also innervated by the deep inguinal. So it's like if you know one, there's like slight variations with the female one, but it's pretty much all the same. So it's kind of cool. You like know one, you'll get the other one down. So this is travel of ejaculated sperm. So people use the mnemonic 7-up. So it starts in the seminiferous tubules, then it goes to the epididymis, then the vas deferens, then the ejaculatory duct. This is emission into the urethra and is nothing, and then through the penis. And then that's going to be your expulsion. Okay? So that's pathway. The pathway, you should know this order. I feel like we got a question on this. It was just the order that like what's the order of like how it moves. But what I wanted to go into just with the histo is if we dive into a seminiferous tubule. So if you look kind of like orienting everyone, it's kind of weird. It like starts down here and then it goes up and it like loops around and then it goes back out. But the testicles, so this is a testes. Here's the tunica albuginea just for like, to be like, okay. Within the testes, there's these seminiferous tubules and they are kind of like, they kind of like go up like that. Like they squiggle. And we're gonna zoom in on the seminiferous tubules. All right. So when you're learning about like, oh, like different types of cells that are, making sperm and whatnot, the two that are gonna come up is Sertoli cells and Leydig cells. So not sperm, I'm sorry. When you're talking about the different types of hormones. So if we talk about Sertoli cells first, the Sertoli cells, these are your epithelial cells. So these are just, imagine epithelial cells. These are just epithelial cells. So the epithelial cells of the testicle is Sertoli cells. Something interesting is, some epithelial cells have like tight junctions. I don't know how much you guys remember from like biochem. Or I don't even know if that's biochem, but like there's like these tight junctions, like with certain types of epithelial cells. Sertoli cells also have tight junctions. So there's something called the blood-testes barrier, which means that like the immune system actually can't get to the testicles. It's called immune privileged, just like the immune system can't get to the brain because the brain is immune privileged because of the blood-brain barrier, which we will talk about. But I just thought that was interesting. It was like there's these tight junctions that don't allow blood to get there. Oh, wasn't the tunica albuginea in the penis? Is it in the testes as well? Yes, good question. So literally anywhere there's like a surrounding coat within like the male system. So that could be around each individual like erectile tissue layer. It can be around the like in first aid, I think it has it here. Down here. That can be here. It's just anywhere that it's like it's being like it's being surrounded by something that's the tunica albuginea. Yeah, no problem. Okay. And then what else do these epithelial cells do? They help with spermatogenesis. They also secrete Müllerian inhibitory factor, which is MIF, and they secrete inhibin B. And inhibin B inhibits FSH, which you'll probably get to with physio, but those are coming. So MIF and inhibin B are coming from Sertoli cells at MIF-B. The Leydig cells, on the other hand, they're not like directly within the seminiferous tubules. They're like in between. So that's these guys here. They're just like on the outskirts. These are producing testosterone. So these are your testosterone producers. And how people kind of remember that is like the ladies dig testosterone. Just so silly, but it works. So ladies dig testosterone because Leydig cells make testosterone in the presence of LH. So it's just a lot of L's. So we have Leydig cells with LH. Sertoli cells are inhibiting FSH, so it's kind of like you can kind of associate the two. And then how there's another way to kind of remember all this stuff here is Sertoli cells are inside seminiferous tubules because, again, Leydig's outside. They support sperm synthesis because they help with spermatogenesis, and they inhibit FSH with its inhibin B. So here's like a histo slide showing it. So again, this is a seminiferous tubule. So it's like a zoomed in basically on like one of those like little green squiggles. So all the Sertoli cells are in here. And then here are your Leydig cells out here. So in this slide, it's even called like, oh, they're interstitial cells because they're in between each of these seminiferous tubules, but they're relevant. Like they're producing testosterone and they're just being important. But the Sertoli cells are going to help with this process of spermatogenesis. So we're going to talk about that next. But I personally don't think they'll ask you to be like, oh, like which one's a sperm and which one's a Sertoli cell. I don't think they're going to do that because who cares, honestly. But remember, the Sertoli cells too are the ones that are making up like the blood testes barrier. Like it's these epithelial cells doing that. So spermatogenesis, know this. I heard that this is still being asked, so still know this. But basically, spermatogenesis it's kind of like oogenesis with like the egg development, but it's with sperm. So this is going to occur from the outermost portion of the seminiferous tubule to the innermost portion of the seminiferous tubule. So you can see this picture here. Here's like if we zoomed in onto a seminiferous tubule, here's spermatogonia. So spermatogonium, this is going to be pretty much like your, what's it called? Like it's stem cell, pretty much. It's pretty much like a stem cell. It goes through mitosis, it splits. We can do mitosis, meiosis another day. No one wants to talk about that now. But it goes through mitosis. We get two cells. This is now called the spermatogonia, and this is kind of where it starts. Then the spermatogonia, and notice like that's going to be the most, like the outermost layer of where the seminiferous tubule is. With each division, with each meiotic division, we're going to go to primary spermatocytes. Then you have another meiotic division. Then you're going to go through secondary spermatocytes. And then you're going to just keep going through it, blah, blah, blah. Then you're going to get spermatids. And then from here, once you have spermatids, now this process switches from spermatogenesis to spermiogenesis, which is silly, but sometimes they'll ask it and be like, what is relevant in spermatogenesis versus spermiogenesis? Spermiogenesis is kind of, you can think of it as like you have like a spermatid, which is like a very immature sperm, and now we're just making it look more like a correct sperm, basically. That's spermiogenesis. So you're giving it like all sorts of stuff. Like like the acrosome, for example, it acquires an acrosome during spermiogenesis, and an acrosome basically allows it to like penetrate the egg. It has like these enzymes in it that allow it to like drill a hole essentially into the egg so it can fertilize it. But that's this process. Know this order. So it starts with the spermatogonia, then it goes to a primary spermatocyte, secondary spermatocyte, spermatid, and then spermatozoa. So notice that the mature sperm is going to be like all like the most, like the innermost from where the seminiferous tubule border is. And so if we go back to this image, that's kind of what they were trying to do. Here's your spermatogonia all the way up here. Then we have your primary ones. Then you have your, where I don't even know what they don't, oh, here's, I guess they're underneath. So secondary ones, and then your spermatids, and then your true sperm are going to be like in the middle. Okay. All right. Moving along. Okay. So that was male reproanatomy. Female reproanatomy. If I wanted to at least include all of the parts to it, I really don't go in. You'll even see I don't have that many slides with it. What makes this difficult, in my opinion, is the blood supply. So I have a picture. We'll talk about it, but I feel all of these things get supplied by different arteries, which is fabulous. But basic overview is this can be, the female reproductive tract can get divided into two tracts, basically. You have your upper tract, and then you have your lower tract. The upper tract, all of these things are located in the pelvis. So what's included in the upper is going to be your uterus, your fallopian tubes, ovaries, and cervix. And I'll show you on the next slide where all these things are. And then your lower genital tract is going to be everything else pretty much. So your vagina, which is still included in the pelvis, and then the vulva, which is also known as the perineum. Well, it's included in the perineum, sorry. So it's like the location of it is in the perineum, where everything else is pretty much located truly in the pelvis, okay? And then again, because this is like pretty much the first, medical aspect of these things. So the uterus, this is where embryos implant, and this is where a woman gets pregnant. This is where the fetus develops, is in the uterus. The cervix is going to be like the very bottom part of the uterus, and again, I'll show you a picture. The ovaries, these are the female sex organs. So these are going to be paired just like the testes, but now we're in the female. The vagina is the hollow muscular structure, and then the vulva is going to be pretty much all of like those outer structures, which I honestly didn't go into too much because the reason why is I think second year when you're doing like pathoma and you're doing path, he goes into all of these things so much because he talks about the pathology states associated with all of these like vulvar pathology. I think he has like a chapter called vulvar pathologies. So you'll go into it. It's just you can see it. I'll show you I have a picture at the very end, and they'll all be on there. This is going to be important though this year for those analogs. So like, what is the male analog of the labia majora? What's the male analog of the labia minora? Blah, blah, blah. Okay. All right. So this is starting off just a posterior view, I guess. Because remember, again, this is again where I'm actually gonna skip ahead really quick. Just I don't know. Oh, maybe I don't have a picture. I wanted to show you because like in the male, where's that picture? This one, which is like really easy to see and it's nice. This is clearly a male, right? Because there's no uterus. So it gets the cross section gets a little tricky when there's now it looks like another bladder, basically, is what I'm trying to say, but it's really flat and it kind of goes backwards. So that's the uterus. It's kind of weird to see on cross section on the side. I might try and throw in a picture for you guys though when I upload this one, so you can kind of see it. It's a very weird thing. So this is the back because it does kind of go back like that. It's really odd. But anyway, looking at it, here's your uterus. So this is your uterus right here. It looks like a little upside down triangle. There's 3 layers to it. Again, just like the heart, just like the lung, let's go with the heart. So there's the endometrium, which is going to be the innermost layer. This is what sheds during a period, the endometrium. We have the myometrium. This is the muscular layer. And then we have the perimetrium, which is the outermost layer. Okay, so that's uterus anatomy. Well, no, not entirely. Because then there's all these other terms. So, and I didn't like box anything because I think this is all important to know. Because for example, if they talk about the uterine fundus, that's the very top of the uterus, right? I don't know if any of you guys have heard of like fundal height I think it's height, fundal height when someone's pregnant. They'll really talk about fundal height because they're talking about how much is the uterus growing. Is it appropriate for how many weeks the woman's pregnant and whatnot. So that's what they're talking about. They're talking about the fundal height because the fundus, they're tracking this size. Then you have the body, and then you have the cavity. The body's just the whole thing. The cavity is like going to be, again, where like an embryo would implant or whatever, it would be within the cavity. The isthmus, the fallopian tubes also have an isthmus. Usually when you see like an isthmus, it's like a narrowing of. That's kind of like what isthmus is. So it's like the narrowing of the uterus happens at the isthmus. And then you have this, what's known as an internal os, and you have a cervical os. This is kind of like where I was like, oh, remember with anterior pituitary, it can also be called adenohypophysis, and they use it interchangeably. Here's another instance of this. So if you see the internal os, this is the internal orifice. And basically all they really mean by this is like, again, it's like before we have like the cervix, because the cervix is going to be right here. It's going to be basically the start, so to speak, of the uterus. Because again, sperm's coming in this way, right? So it's coming in this way. So this is going to be like the start of the uterus. Then it goes through the cervix. When it enters the cervix, that's called the external orifice. It's also called the cervical os. So a lot of times you'll see with like pap smears, on your OB-GYN rotation, they might talk about like, oh, like the cervical os was normal because they're looking for cancer in this region. And that's all they're talking about. They're just talking about the cervical region because again, they're checking for cervical cancer. Then it goes through the cervical canal, and now we're at another orifice. That's the internal orifice. That's the internal os. It's really not super clinically relevant. I think it's just the true transition now to like we're the cervix and now we're the uterus. So that's kind of the internal orifice. Then it kind of switches to the uterus, which we talked about. All right. Fallopian tube, I have a whole separate slide on that. And then the other thing I wanted to mention is, remember in GI we talked about like all of the mesentery that's present. What's super interesting is like every single thing in the female reproductive system has its own mesentery, which is super cool. It's because, again, remember mesentery's whole point was to kind of keep everything in place in the GI tract. It is super important to keep everything in place in the female reproductive system. So they have tons of mesentery, and you can see it. It's like, oh, the mesosalpinx. This is mesentery of the salpinx, which the salpinx is another name for fallopian tube, which again, we'll cover the fallopian tube. So that's mesosalpinx. The mesovarium is the mesentery of the ovary. The mesometrium is the mesentery of the uterus, like because that's the, where the metrium, the myo, endo, and perimetrium are. There's four, no God, important like ligaments. So your ovarian ligament is the first one, I would say. This connects the ovary to the uterus, okay? So right here, I'm trying not to draw too much, but whatever. So ovarian ligament connects the ovary to the uterus. And these are good to know because again, like let's say you have ovarian, like sometimes the ovary can twist around itself. They'll ask what ligament is doing the twisting, basically. They call that torsion. It's the ovarian ligament. So it connects the ovary to the uterus. The round ligament, it's not shown here, but it connects the uterus just to like the wall, of the, again, you're trying to keep the uterus in place. So that's the round ligament. We actually talked about the round ligament, fun fact, in GI when we talked about the liver. And I was like, this will actually come up in Repro anatomy. So you can go back to those slides. But that's the round ligament. It's the same one. The broad ligament is massive. It's actually like a combination of just like everything. So you can see here with all the mesenteries, the broad ligament surrounds basically the entire thing. Remember when I said like with GI, if you just open up the abdominal cavity, it's just like mesentery. It's kind of the same thing. You look at the female reproductive system, it's just like broad ligament. So it's massive, and it's a combination of all these different mesenteries kind of coming together. That's your broad ligament. And again, yes, it's very broad, and it keeps going over here even, so you can see it comes over here. It just like surrounds the entire thing. So that's 3. And then the last, well, there's 5. All right, so we decided. The infundibulopelvic ligament connects the infundibulum of the fallopian tube, which we'll talk about, I think, on the next slide, which is right here, and it connects it to basically, again, the wall. So infundibulopelvic, so it's connecting it to like the pelvic, like a part of the pelvis. And then lastly, yes, the cardinal ligament. So here's the cardinal ligament down here. The cardinal ligament just kind of connects the uterus again to the wall again, but it's a little bit more like the broad ligament is just like it connects just like everywhere, right? And the round ligament, same thing. It kind of connects the uterus to the wall. Cardinal ligament does the same thing. It's just like locations wise. So if they point to one of these ligaments and like which one's this one? Like the round ligament's all the way up here, the cardinal ligament's closer down to like where the cervix is. Okay. All right. I think that's everything on this slide. And now the parts of the fallopian tube. So the fallopian tube, and you'll kind of go through this with like phys of like how ovulation occurs and how like an egg is released. But here's your ovary, here's like a follicle, and eventually this will rupture and it'll release an egg. And what's really interesting is the first part of the fallopian tube, I think they look like little fingers. I put this in the wrong order. I should have went up this way, but it's fine. So the first part of the fallopian tube that grabs the egg is the finger part. So it's the little fingers, and that's called the infundibulum. So this is the infundibulum, and it kind of like it snatches the egg, and now the egg is going up through the fallopian tube. The next part is the ampulla. So the ampulla of the fallopian tube, this is usually where fertilization occurs. So, because remember, the egg is going this way, the sperm is coming up this way, and now it's a race to the egg, right? Usually fertilization occurs here, and then it travels, and then it implants in the uterus. Sometimes, though, when you have ectopic pregnancies, they can also implant here. So you can have fertilization here, and you can have implantation here. That's ectopic pregnancies. That's very bad. That's like a surgical emergency. And remember, this word ectopic comes up again because remember, whenever you see the word ectopic, it means something is happening where it's like outside of where it normally happens. So a pregnancy normally happens, like implantation normally happens in the uterus. This is happening in the fallopian tube. So that would be an ectopic pregnancy because it's outside of the normal location. Okay, so that's the ampulla. The isthmus is the narrowest, just like with the uterine isthmus, it's the narrowest part, same thing here. And then just the uterine part, which I don't even know if it's on this. Yeah, it's not even on this slide. It's just like, whatever, it's a fourth part. It's fine. This is what's going to basically tether the fallopian tubes to the uterine cavity. Okay, but the three main are the infundibulum, ampulla, and isthmus. Ampulla is important for fertilization as well as ectopic pregnancy location. Infundibulum grabs the egg. Isthmus is just the narrowest part. And all of these kind of combine to make your fallopian tube. Another name for it, which you can see, is the uterine tube. So if you see that, it's the same thing. Okay. Blood supply, there's a lot here. I highlighted them because it really is just going to be like a memorization game. Luckily, though, they kind of tell you what they're supplying. So, for example, the female reproductive system in general exclusively is supplied, well, almost exclusively, is supplied by the uterine arteries, which is number one. If you notice here, they're a branch off of your internal iliac. So here's like where the aorta branches into your iliacs, and then you have your common iliacs, and then you have your internal and external iliac. And then the uterine artery is a branch here of your internal iliac. Sometimes I like to ask that. Again, I always put like where it's a branch from because sometimes they'll ask that. Where's number 2? So this is, this is a good picture of the broad ligament. So you can see they cut it away, but it's just all broad ligament basically. The uterine artery is going to pass over, so superior and anterior to the ureter. And I have a fun way. Yeah, so here's your uterine artery, the same one we just talked about. Here's your ureter. See the yellow? This is the ureter. See how the uterine artery goes over it and in front of it? It kind of goes like that over this guy. People remember this because they say water over the bridge. Sorry, oh my God, water under the bridge. So water, because it's in the ureter, under the bridge is the uterine artery. Okay? All right. Because sometimes they'll ask that. They'll show you a picture and then it'll be like, oh, like, is that the ureter? Is that the uterine artery? And you're like, which one was in front? So the uterine artery is in front because water goes under the bridge and the uterine artery is the bridge. Okay. And then number 4 is the lateral wall. So you can see when the uterine artery kind of comes up, it kind of like starts to go like this and it's just sending off branches. So that's kind of like where, I don't think on here, it has some arteries labeled on here, but they're pretty much all just like branches of the uterine artery. But they do give them like names, like they do kind of give them names. But regardless, the uterine artery is the most important. But it sends off a vaginal branch, which is number 5. So here's your uterine artery. It sends off this vaginal branch. It's going to go down and supply the vagina. And then it supplies a ovarian branch, which is number 6. So I don't know how that connects to the ovary, but whatever, which is also a branch of the uterine artery. Okay. So it tells you what it's supplying. It's just kind of annoying, to pick these out of a picture. It's kind of annoying. All right, this is going to be where they're going to get you on questions. So the uterine artery and ureter. Remember, things are not color-coded in real life, right? The ureter is not green, the uterine artery is not red, or it's not yellow and red. So sometimes what can happen is during a hysterectomy, which I put down here for you guys, is like when you just take out the uterus, when it's like the patient takes out sometimes they do this for, they have cancer or something happens or they just want a hysterectomy, so they get a hysterectomy. What they need to do is they need to stop blood supply to the uterus, right? If they need to take it out. So they'll clamp the uterine artery to stop, because again, the uterine artery pretty much supplies all of the female reproductive tract. Sometimes the ureter is accidentally clamped. So this is where it's really important to remember that the uterine artery goes over the ureter. It's water under the bridge. So instead of it looking like this, a surgeon sometimes is working with this, and he's like, yeah, something's happening here. So just keep that in mind, that things are not color-coded. But a lot of the times when they're asking about a hysterectomy, they will straight up talk about how patient got a hysterectomy and now they're having all these urine symptoms, like just weird urinary tract symptoms. And you're going to be tempted, especially on boards when you don't know it's a repro question, you're going to be tempted to think like, oh, maybe they have a UTI or like maybe something weird's going on. But it's likely that during that hysterectomy, they likely accidentally clamped the ureter instead of the uterine artery. And then now they're having all these issues, they're having all these renal symptoms because of it. All right, this is kind of it's pretty much the same slide, but like I told you, it's very, very similar to the male. So again, if you remember, the testes in the male are para-aortic, the ovary, the analog in the female are going to be the same one. Okay, Everything else, it gets a little trickier though, because there's like a little bit more parts in the female than the male. So it's kind of like, yeah, it's still like the superior part of the bladder, like it was in the male, but now we also have the uterus and the cervix. Okay, yeah, so this is the cross section I was kind of talking about. So see how like the bladder's down here? This is the uterus, and it kind of sits like folded back. So everything we were talking about was like back here, and then it kind of leans forward like that. Okay. And then everything else is pretty much the same with the analog. All right, and then one more slide. This is what I was mentioning. So this is this is gonna be the most annoying thing to memorize, but this is like a you need to know. Like this is just gonna be like random questions. They'll be like, what is the female analog to the bulbourethral glands of Cowper? Or the Cowper's glands. It's going to be the greater vestibular glands of Bartholin in the female. Like they'll just ask that. Another thing they'll ask besides the analogs is the embryologic development. So before it's decided, is this going to be a male or is this going to be a female? They all have like the same things, and then either estrogen or DHT, dihydrotestosterone, tells it like, oh, you're going to be a male, or oh, you're going to be a female. It not really like tells it that, because there's other factors which you'll get into. That stuff's confusing. Like how you know you're going to be a male or a female. Everyone is pretty much born a female. There has to be like an extra step to become a male. There's like an extra step to make it a male. But this is talking about external. So that's internal. This is talking strictly about external anatomy. So external anatomy is primarily in males dependent on DHT and estrogen in females. Internal anatomy is dependent on testosterone in males and then estrogen still in females. Which hopefully this will make sense when you start doing that type of stuff in LIs and stuff. People always get confused and forget that it's DHT, dihydrotestosterone, which does the more superficial male anatomy, the external male anatomy, versus testosterone, which does the internal male anatomy. And in females, it's estrogen for both. But they can ask this. And actually, these were some questions I had on my exam during first year, because I was like, I hope they ask about this, because I studied this, because it's so annoying to study. But you should know, like, okay, the genital tubercle develops into the glans penis in a male, or the glans clitoris in a female. Those are your analogs. But what is the thing it developed from? The genital tubercle. Okay, so this can be something you even like save if you want for like right before the exam, but like definitely go over this, because this is like not something you can like reason through in a question. It's like you know it or you don't know it. All right, and then here's my little reminder to review inguinal hernias. So I put where it is, and then I also have, don't forget to do the hernia questions associated. I think I recorded them separately. I can't remember. So just look for those, because all those are really good ones for this exam. And then finally, also on your syllabus was fetal circulation. So fetal circulation, I talked about it with cardiorenal. So that's pretty much the extent. Just remember, like, arteries and veins are switched in fetal circulation. Know those analogs, or not analogs. It's like this develops into this after the fetus is done developing. You know, the ligament, like the ductus arteriosus turns into the ligamentum arteriosum. Like, know those structures. And I have where to find that. And yeah. So there are a lot of questions. So I think that was a lot for the day. So I think I'm going to let you guys do them on your own. And then I can even like record going through them like I did for one of the other PowerPoints. But it's just, there's a lot of questions. We'd be here for like another hour. But I tried to give you as many as possible. Yeah, you're hungry. Yeah, I understand. It's a lot too. Repro anatomy is a lot. All right, so I'm gonna stop record. No, wait. How do you stop recording?